All right, thank you, Professor Berman. Thank you, Professor Sharma, for organising the session, and also my panellists as well. So I'll just open my talk. So I'm going to talk about proliferative retinopathy, which is something we all deal with as general ophthalmologists or retina specialists, whatever that may be. I'm really just going to provide an overview of the understanding of PDR. It's really just presenting both sides of the story in terms of, our understanding of the disease and how, we manage the disease and whether or not it has actually changed the treatment paradigms. So with respect to diabetes in general, we all know that the disease is something that's not going away. In fact, it's something that's certainly getting worse both in Australia and in Asia. And it's projected that over the next 20 years, we're going to be dealing with a much larger clinical burden of diabetic retinopathy related complications. And if we looked at the subsets of diabetes, in type 1 diabetes, the risk of proliferation is nearly 40% over 14 years. Whereas in type 2, it's nearly 22% over 15 years. So there's a lot of patients that are going to require treatment in some form to preserve vision. I think our understanding of the natural course of diabetic retinopathy is limited, but this is one of the best papers I think we have in terms of sharing clinical data about the way diabetes progresses in the eye. This is a paper published nearly 6 years ago, looked at 65,000 patients in Germany and followed them over an extended period of time and just looked at the rates of development of proliferation, macular edema, and so forth. And this graph really sums up the study very nicely, I think, because there's you can see that the risk of proliferation is not linear. In fact, the risk of proliferation increases with time. Some people will never get proliferative retinopathy, and a lot of people, after a certain point in their disease, their risk of developing proliferation is very high. Compare that to the patients that develop maculopathy, where the curve is much flatter. So this again gives us evidence that the pathways and the genetics behind developing diabetic macular edema and proliferative retinopathy may actually be quite distinct and different. The risk factors for developing proliferation, the risk is greater in type 1 diabetes. The longer you have diabetes, if it's poorly controlled, and also if you have great variability in the blood sugar levels. Systemic risk factors for proliferative retinopathy include renal disease, hypertension, and also neuropathy, which is the new risk factor that has been shown to be very useful in prognosticating the risk of vision loss. So I'll just share a case with you. This is a patient of mine that I saw several years ago. She's young. She's had type 1 diabetes for 24 years. And when I saw her in 2017, she looked reasonably good. I thought she had moderate non-proliferative retinopathy. I reviewed her again annually, but 2 years later, this is what her fundus looked like. You can see that she's had marked progression of the retinopathy, and now she's got retinal neovascularization and peripheral ischemia bilaterally, despite being a vision of 6/6 in both eyes. So this is a subset of patients that I just want to draw attention to. So there is a subset of patients that are at risk of developing PDR, but there are also those patients that are at risk of developing rapid PDR. Rapid being that they have several stepwise progression of retinopathy beyond what you'd expect. And these patients are those that have a severe change in their HbA1c, whether it's an increase in HbA1c or a decrease. And the studies have shown that if the HbA1c goes from being 8 to 10%, so there's a 2-point progression, then the risk of proliferation is actually increased by 30%. We're getting more and more evidence to tell us that patients with renal disease are at really high risk of developing proliferative retinopathy. And in fact, in this patient, that was the exact cause of her disease progression. Over the course of 2 years, she developed severe chronic renal failure and was on the verge of getting renal dialysis. So I think for her, that's what tipped her over the edge. Again, going back to neuropathy, that's an increasing risk factor for the development of rapid proliferative retinopathy. So patients that are otherwise well, and over the course of 1 or 2 years now have developed peripheral neuropathy and foot ulcers, those patients probably should be watched more carefully. And of course, pregnancy in female of childbearing age should never be forgotten, because that's sort of a risk factor that we may forget about. If you talk about the pathogenesis of proliferation, if you looked at the literature, most of the evidence or the concepts regarding proliferation come back to ischemia, hypoxia, and vascular endothelial growth factor. And I think this schematic diagram from a review paper in 2002 sums it up very nicely. You can see that there's a pathway of hyperglycemia being the induction of a number of biochemical pathways, all of which end in the upregulation of vascular endothelial growth factor, which will cause retinal neovascularization. So let's take a look at that using a clinical case. So this is another patient of mine that developed proliferation over the course of 1 year. So this is the angiogram in 2018 before I was convinced they had proliferation. And in 2019, they had obvious leakage on the angiogram. If you look at the site of retinal neovascularization very closely, what you will see quite clearly is that there's been quite a lot of capillary non-perfusion surrounding the area of retinal neovascularization. So this certainly supports the concept that ischemia and progression of capillary non-perfusion is a major risk factor for retinal neovascularization. If you take a little step back and just looked at the histology of diabetic retinopathy, this is work done by one of my PhD students, Dong-An, who has been studying the mechanisms underlying diabetic retinopathy for the last 4 years. This is a histology of the donor eye. So he's labeled it with antibodies for different things. And there's really 3 elements that I want to pay attention to. Anything labeled in red is highlighting vascular elements. So pericytes, endothelial cells, smooth muscle cells. Things that are false colored in blue are glial cells, mainly Muller cells and astrocytes. And anything in green are the neuronal elements, so bipolar cells, ganglion, amacrine, and horizontal cells. Really important to remember that these structures don't work in isolation. There is a very strong communication and interaction between these things, and this is what we refer to as the neurovascular unit. And that's often we forget about that in proliferative retinopathy very often. But I think we're learning more about neurovascular units and neurodegeneration in diabetic retinopathy because there's more and more evidence. Since everyone is now using OCT, we're starting to see the manifestations of neurodegeneration in diabetes, something that happens very early in diabetic retinopathy, particularly in type 1 diabetes, is nerve fiber thinning. And we can capture that quite clearly on OCT. And we can see that often even before the earliest vascular changes such as microaneurysms form. So neurodegeneration is a real concept that is occurring in diabetic retinopathy. There's probably several pathways causing neurodegeneration, and it's also modulating the course of vascular change also. How do we treat diabetic retinopathy when it proliferates? The main way is PRP, and this is a technique that was described 45 years ago. This was the paper presented by the Diabetic Retinopathy Study Research Group, and it showed very clearly that patients that had PRP did well long-term. So this is a different patient, another type 1 diabetic who's 38 years old, presented with 6/6 vision to my practice for the first time after 21 years. And you can see that despite an acuity of 6/6, I mean, these changes were picked up by the optometrist. They've got fibrosis in the inferior periphery and the inferior retina. And the angiogram shows severe ischemia peripherally and also nearly 360 degrees of circumferential neovascularization. So how did I treat this patient? Well, I treated them with PRP and they did really well. So this is 6 or 12 months later, the neovascularization has regressed and their vision is still 6/6, and I'm confident that they're going to be 6/6 for a long time. So PRP is a good treatment, but how does it work? We don't really know. It's the short answer. People have tried to study this, but we haven't reconciled the mechanism. One way to look at it is to go back to the histology of retina once you've applied laser to it. If you looked at this histology, this is from a paper published in 2013. This is in the human retina. You can see that areas where laser has been applied, the inner retina is largely preserved. It's the outer retina that's disrupted. Remember, it's a thermal reaction between the RPE and the outer retina. And you do get loss of dysfunction of photoreceptors wherever you apply laser. Professor Kringle and Professor Yu, they both work in Perth, Australia, and they've done research on retinopathy for over 30 years. To my knowledge, they're the only group that have tried to look at how oxygen consumption changes in the retina after you apply laser. And they did some very elegant studies using animal models where they lasered the retina and then they took measurements using very fine micropipettes running it through the retina. And what they actually found was that when sites where you applied laser, the inner retina oxygenation increased. So one mechanism by which PRP works is probably by reducing the oxygen consumption of photoreceptors, because you have less of them after laser, and increasing the oxygenation of the inner retina. But I'm sure there are other mechanisms by which laser works. We just haven't worked it out yet. The other way that we can treat proliferation, as Dr. Raja just went through, is we can apply anti-VEGF. Anti-VEGF works by decreasing permeability of the circulation, so you can treat macular edema, but also it can inhibit angiogenesis, which is the pathologic growth of new vessels. If you start giving it in normalized, it inhibits vascular genesis and can cause all sorts of problems as well. This is also some work Dr. Raja just described, but I'll go through it in a little bit more detail. This is probably one of the best studies, I think, which have linked vascular endothelial growth factor to the progression of retinopathy and the induction of retinopathy in diabetes. So this is by the Boston group in the USA. And what they did was they injected VEGF into the vitreous in normal monkeys, and they showed that the changes we were getting in the vasculature were very similar to what you would see in human diabetic retinopathy. Very nice paper. And we can prove that anti-VEGF works. So this is another patient of mine who presented with retinal neovascularization, which you can see on all three imaging modalities, treated with anti-VEGF. And I've got them back to the clinic 1 week later, and you can see how quickly the anti-VEGF work. It causes neovascularization to regress very rapidly, and it's an excellent treatment for doing that. This is a different case. This is from Bailey Freund in the USA. This is a patient that's had multiple anti-VEGF treatments for proliferative retinopathy. And look at how well the retina looks at the end of it all. You could almost fool yourself into thinking that you're looking at a normal eye after 2 years of anti-VEGF treatment. So the retina looks really good. The bleeding's gone away. But probably the most important point I want us to take home from this talk probably is that anti-VEGF does not cure the problem of diabetic retinopathy. The fundamental problem that causes capillary non-perfusion and progression of degeneration of the retina is not cured by anti-VEGF. So I'll illustrate that with this case. This is a patient that I was treating with anti-VEGF for proliferation, and the eye looked very good 4 months after 4 treatments. You can see that the staining of the vessels has reduced. There's less capillary leakage. The neovascularization in the infranasal retina has regressed. We were all happy to stop the treatment, but this is the eye 6 months after stopping treatment. You can see quite clearly that you're back to square one. You might as well have not given the 4 treatments to begin with. The French group looked at the effects of anti-VEGF on retinal perfusion in a really nice way. They looked at fluorescein angiography and OCT angiography before and after treatment with anti-VEGF. And this study, in many ways, confirmed what a lot of us suspected, in that what anti-VEGF does is that it reduces the hemorrhages and it resolves the neovascularization, but it actually doesn't restore non-perfusion. And you can see quite clearly on the OCT angiogram images in the lower panels that the OCTA areas of non-perfusion before and after therapy has not changed. I think the clinical evidence for anti-VEGF in proliferative retinopathy really comes down to Protocol S by the DRCR-NET, and they compared PRP to anti-VEGF, and this is the 5-year results. And they found that, there was no difference between the 2 groups in terms of visual acuity. There was more field loss with PRP, but surprisingly, anti-VEGF also resulted in PRP in visual field changes in the periphery. More patients in the PRP group required vitrectomy surgery for vitreous hemorrhage and tractional detachment, which I, to be honest, found very surprising. I would have expected the opposite result. But this is the most important finding for me, is that after 5 years, nearly 40% of patients were lost to follow-up. So imagine treating patients with anti-VEGF and then not seeing them after several years. I mean, we all know from the evidence that I've just shown you that the non-perfusion persists, and in many people will progress. So these patients that have just had anti-VEGF without laser are at high risk of severe vision loss from vitreous hemorrhage and so forth. Probably one promise in terms of anti-VEGF therapy in proliferative disease is the port delivery system, which I'm sure most of you know about. which is something that's being investigated by Roche Pharmaceuticals, where they're using ranibizumab as a reservoir depot system for slow release. It's been shown to be quite favorable in treatment of neovascular macular degeneration. But this is a system whereby we could possibly have slow release anti-VEGF for years, whilst at the same time reducing the treatment load on the health system. So you can see in this video, the port delivery system is being placed in the pars plana, and it's simply going to be a matter of topping it up every 6, 12, or 18 months with the relevant anti-VEGF agent. So in conclusion, just epidemiologically, we're going to have a huge treatment burden of PDR. Please remember that we cannot reverse PDR at this point in time. We don't have the technology or the expertise or the knowledge to do that. PRP is an excellent treatment. It will guarantee long-term good visual outcomes for most patients. So I still think it's the standard of care. And anti-VEGF is effective and has important limitations. And I really hope that I've shown you what those limitations are. The one thing I haven't spoken about is the role of vitrectomy, which I've left to the next talk in the management of proliferative retinopathy. So thank you so much for your time, and again, for the invitation to present at your meeting.